Um, well, I think I'll introduce myself first. I'm Betty Hoog, and I'm the General Manager of the CFS Foundation in South Africa. And we're the only charity working for people with ME and long COVID in South Africa and actually in the whole of Africa. We aim to provide access to healthcare and counseling service for people with ME who can't afford it, depending on available funds and available resources. We also try to raise awareness for people with ME and CFS and long COVID, and advocate for the rights and interests of people living with ME and CFS and long COVID. So that's a boring bit about me. So now just a very warm welcome to all of you here today, those who are here in person at the center, and also obviously those of you who are here with Zoom. Just a little bit background, the Blue Sunday ME and long COVID Tea Party are celebrated worthwhile. So worldwide people are now having parties, having tea and cake, and actually trying to get much needed funds for local charities. In our case, we're trying to collect funds for the ME-CFS Foundation, which we use to the benefit of people with ME and CFS and long COVID. A big thank you to Melindeni Legabella, our long COVID ambassador. Melindeni, you are ill yourself and you had to go to Johannesburg and you only came back last night, but you have initiated this wonderful event in Khayelitsha and the cake and everything. And yeah, you will thank you everybody who's helped you there. But a big thank you, Melindeni. You are our long COVID ambassador and we really appreciate all your efforts. Behind the scenes, there were quite a few people who contributed to the success of today. I must mention Teresa Fenchambesta, who invited press as far as she could, did a huge job. Villa Truta, which did our graphics. Sam, we helped wherever she could and sent her daughter Ruby today to be there and do photos. So thank you very much for that. And then a special thanks to Dr. Uvi Naidoo for his willingness to devote his time and his expertise and be our keynote speaker today. And not only that, he advertised as much as he could, and he's been helping us, and today there on the ground, he will be a man on the ground with Zoom and everything. So thank you, Uvi, we really appreciate you being here. Just a little bit about your background. Dr. Uvi is not only a medical doctor, he's been a patient. And I think actually doctors who's been patients themselves do make the best doctors. But he started his clinical career in Cape Town in 2008. And unfortunately, he contracted the multi-drug resistant TB during his internship at Groote Schuur Hospital. And then had to have 3 years of treatment and life-threatening complications, but at last was cured in 2011. And I think that is where Dr. Uvi realized that at that juncture, the significant scientific gaps that existed in clinical medicine. And being a bright guy, he was awarded a Global Infectious Diseases Fellowship in the US at 2 prestigious universities. But he returned to his own country in 2015 to complete his South African fellowship in pediatrics. During this time, he still remained heavily committed to his growing interest of being translational specialist clinician. And his skill set evolved to help develop novel diagnostic tools and biomarkers to map host immune responses in infection diseases such as tuberculosis. His ambitious plans were sadly dampened when he acquired severe COVID twice in 2020 and 2021. Dr. Uvi, I just want to take the time to say sympathies. I know that your father, Professor Naidoo, succumbed to COVID in 2021. And I think that has prompted you to start the long COVID clinic in Cape Town. But you will listen today to his personal journey as scientist, clinical specialist, and this patient, he will also give his perspectives on the topic of long COVID, a subject that has grappled many clinicians and families and scientists. We hope you will enjoy your program. The ward-moving unrest is extraordinary and is not only informative but entertaining, and that will be shown later on. You guys who want to watch it at home, you can get it on the internet and watch it too. It's an award-winning movie and really, really good to watch. So thank you very much for everyone again for being here and for everyone who worked so hard for this, to make things work today. Big thank you to my daughter, Dr. Madeleine Miller, whose Zoom account we're using, and who's been trying to train a very stupid mom in Zoom. Not very successfully, but at least you tried. But thank you, Madeleine. And with that, I'm handing over to Dr. Uvi.
Dr. Uvi, you'll just need to unmute. Apologies, I muted you while Mom. Just please unmute. Thank you. And then you can just share your screen again.
Super. Can you guys see me and my slides?
Yes.
Okay, great. Thanks so much for the warm introduction. And I think
how to do this.
Yeah.
Sorry,
we just have we have an audience here, so we're trying our best to include them in the visual. So is it okay? Can you guys hear me well from here? Okay, great. Can you guys hear me?
We can hear you well.
Okay, great.
Yeah,
warm welcome, everybody. Ladies, gentlemen, community members, people of the press. I'm hoping we're getting a few clinicians on board, healthcare workers, and any community stakeholders. As with my upbringing in a small little suburb called Chatsworth in Durban, being in Khayelitsha today, it reminds me a lot of how I grew up with a sense of community. And when I look at the ME/CFS community, long COVID patients, and what we all had to go through for the last 3 years, when we look back at 2020, I think events such as these just bring community to the fore. And I'm super grateful and privileged to be here. Thank you very much for inviting me. And I hope I could give you a little bit of a snippet of my personal perspectives. I have no conflicts of interest, and these are my personal opinions. And I think these days, personal empathetic experiences translate a lot better than evidence, black and white evidence on paper today. And that's currently what my talk will entail. And I hope it can assist many ME/CFS, long COVID sufferers, families, healthcare workers, moms, dads, and especially on this day, on Mother's Day, we hope to ignite a sense of family within the community we're trying to offer and lend our support. So I'll just stop my talk. My talk is called Long COVID Today. I'm just going to be a little bit on the mic here. You can just tell me if there's an echo.
Dr.
Okay?
Naidoo, would you please just swap to slideshow at the top there? So at the moment we're seeing you on presenter view on the Zoom.
Oh, sorry, my
Just go to, yes, that's perfect. Thank you very much.
You're welcome. Okay. So, okay, cool. So my talk today is long COVID today. It's a dire need for empathy in the sciences. And I speak to you today as a laboratory scientist, a pediatrician that sees patients every day, as well as a patient advocate. So any of you here today or have family members that have been affected by the complications of COVID or other viruses and bacteria and have become aware of the terminology ME/CFS, I speak on behalf of you. I too am a patient, and I will relate to you my personal story. And I hope it can be of assistance just to help close gaps and just get us closer together to helping ease suffering at a patient level. Just moving my slide. Cool. So in 2013, I had given this talk at the South African TB conference in Durban. And I was a marathon runner in 2007, 2008. I just finished medical school at the University of KwaZulu-Natal. I was training extremely hard. I lost about 15 kgs in the space of 6 weeks. Had severe tuberculosis, which was drug resistant in my lungs. I experienced a lot of egos as very esteemed professors and senior doctors that were managing me, where very little of empathy was brought through. But when I was that severely ill, we had to rely on expert opinion. So I had many life and death experiences, resuscitations in an ICU setting as a patient. It took me 3 years, 1 week and 1 day to be cured. This talk, I basically was 10 years ago in March that I mentioned severe gaps that science does not translate to the patient that we see in the hospital or the clinics or in our private practices as doctors. And I spoke of the exact same words of using a lot more empathy to translate science to the basic community. Fast forward, as Betty had told you, I had become a laboratory scientist clinician for tuberculosis in South Africa, as well as internationally. I came back to South Africa and have been doing a cosmic dance between Austria and South Africa. My wife is Austrian. So I was specializing there, doing a PhD in South Africa, and planned to do a PhD working abroad and in Cape Town to handle TB in children in South Africa. The 2020 wave had hit, and sadly, I succumbed to tuberculosis. And I'm just going to show you the slides. So this was in July 2020, whereby I got very ill. I ended up in ICU twice in the year 2020. On the background of my severe lung disease from tuberculosis, there's a lot of unknowns with COVID, but a lot of unknowns with somebody who had severely drug-resistant TB and severely scarred lungs. So I was alone in Cape Town. My partner, fiance, is trapped in Austria on lockdowns, and I was trapped here working in hospitals until I got sick. And I remained in isolation on oxygen more or less for about 4 months. During that time, without family support or any friends visiting me. The theory was that if you were on oxygen, you were contagious. So with the fear and anxiety that COVID brought on, there was a lot of fear for people to touch you, the stigma attached to COVID, and I think we all can connect with that story. And I'm just going to go backwards in the slides. Sorry, some slides just jumped in. And I would have gone back. I moved back to Durban to be closer to my mom, dad, and sister. It would have been the last month I would have spent with my father, fixing geysers on the ceiling on oxygen, load shedding problems, fixing electrical problems. And he and I really connected with my health. He was an astute family physician, community leader, and advocate for his patients, and always believed in the comment, patient-centered care, putting patients first. And he would see his elderly patients that were 80 years old. It was a couple on the last week, just after Christmas. And that couple both had COVID. He was one of the few doctors in private that were doing house calls to see sick patients. And these were one of his oldest patients. They sadly gave him COVID, and he brought it home and gave it to my mom, my sister, maybe myself. I had a neighbor, as you can see in the slide, that's my mom, and the funeral hearse in front of my neighbor that I grew up with as a small boy. His name was Uncle Wally. And I'm sure in African communities it's the same as Indian, where when you grow up in a community, everybody on your street is an uncle and an auntie. And that's my mom. I'm not, I'm very, I believe as a clinical doctor, my job is to interpret how people suffer. And often when people suffer, they cling to faith. And I've always been taught by my dad, that is the job of a doctor, to interpret how somebody wants to get peace to his suffering. There's a picture of my mom praying for Uncle Wally, who I did resuscitation on, who passed away 2 days before. I broke rules, and out of love for him, I looked after him because he battled to breathe and got him into ICU. And I think that he perhaps could have given me COVID again for the second time. That was our final farewell to him. My dad was behind my mom's, lying in the balcony, COVID positive. He was significantly ill, and thereafter took about 36 hours until he completely crashed with massive clots in his lungs to COVID. And I managed to, he was a professor of medicine with a lot of students around, and we managed to get him at Isivivana Hospital, which was very difficult in those days to get a patient into a hospital that had COVID. And a lot of people unknowingly died of COVID or just without support. And I think I was very privileged in my family to have had the support that unfortunately most of my patients in the private or public sector never enjoy, even before COVID. So we got him admitted, we got him into a pediatric bed that was converted into a high care. Nurses were just scatterbrained, people were dying every hour more or less. I lost 25 colleagues during this spell, including my own father. My father was COVID positive, but he was worried that he was serving the community and being a doctor till his last breath. So he was worried and felt guilty that he gave COVID to my mom's sister and my little niece. So while he was stuck in the ICU bed, you can read the screenshot. I had to lie. My sister, I named Akka, and my mom and niece is Hara, and I had to lie to him that they were all COVID negative, just so he could focus on himself. And, I think when I look at you all in the audience or anybody listening, we all have a memory of somebody we spoke to before they passed or before they suffered. And I think it's something that stuck with me. These are the last few conversations I had with my father while he was alive on this planet. This would be the funeral I had of my dad. And it was the last rites I had to do for him. His body lied in a plastic casket outside our home for about 45 minutes. And my mom got admitted 2 days after he died, sadly, before this. This was a week or 10 days after he died, this funeral. My mom crashed with COVID, pneumonia, as well as my sister with seizures to COVID. My sister's also a doctor. And I had to lie to my mom for 7 days to get her out of ICU, so we could get a better focus on herself and plan the funeral for my dad. I had my little niece alone at home, so it was quite trying because I had my mom's sister and my late dad all in the same hospital, and I wasn't sure if anybody was going to come home. So this funeral took a lot of strength. As a pediatrician, I break the news to families sometimes. Sometimes we get it wrong as doctors. We're not of godly, but we try our best as middle people to help ease suffering. But breaking the news to my mom that her partner of 46 years was no longer. So she never got to see his body. She never got to say goodbye. And her last thing was touching his coffin. And that's her there with my little niece next to her. And when I look at the journey now, my dad's last wishes were to open up a rehabilitation center. And being with my partner in Austria, I learned a lot of what other countries did in terms of healing people. And the European Union, the EU, European countries seem to have got it right, in my opinion. We have a country of really brilliant clinical doctors and brilliant scientists. There's a lot lacking in our system. We all complain about our governments and lack of resources, etc. But what the Europeans focused on is rehabilitation. And that was my late dad's last wishes, to open up an immune center and help as many post-COVID or chronic sufferers with immune problems. And that was the brainchild of what I'm doing today to respect his last wishes. William Osler is regarded as one of the fathers and great philosophers of medicine, and a lot of us in medical school will learn of his quotes and his clinical science that we quote for exams. And very simple, common things occur commonly, and so is common sense. And his words were teaching us all as medical students. Listen to your patient. He or she is giving you the diagnosis. And I wonder how many of us sit in a doctor's office these days where you feel someone is listening on the other side, or at least empathizing. So it comes to my talk, long COVID. Sorry, I went in with my personal story, but I often find that connecting with people through your own personal story, I very rarely in my own health, I've met a doctor speak casually about his own personal struggles and personal journeys. And we were all so humbled and connected from 2020 onwards. I'm from KZN, so we had floods and riots and lack of community, and it made people feel very alone and isolated. And I am now a long COVID patient. As you can see, I'm on oxygen. It's a lot less than what I am. I'm much better. But I just had flown after seeing my mom on Mother's Day just to keep my family strong while attending to patients. And I'm just grateful to be with you all. So when we look at long COVID, it's just a little bit of facts and figures. There's about 651 million people estimated with some sort of post-COVID history. And those are only the patients that have tested for COVID, not the ones that have not. So we estimate that about 10% of that 651 million people have long COVID. So it's an underestimated guess, but that means 65 million people worldwide could have COVID. We look at our own numbers in South Africa. I'll come to it with the NICD slide. We also that aggressively when we're looking at President Ramaphosa's addresses to us. So when we look at, I'll come to South African figures in a second. The incidence today, when we look at COVID, of the 65 million people worldwide, around of those numbers, maybe about 50 to 70% of hospitalized patients in that number likely have long COVID. 10 to 30% of those patients that were not hospitalized. So what doctors did, we started labeling things mild, moderate, severe COVID. So of the mild COVIDs, which you thought was nothing, 10 to 30% of those mild COVIDs are suffering chronic long COVID symptoms. We tried to push vaccines, and this was a new generation vaccine. We've never used mRNA vaccines ever, the Pfizer the Moderna vaccines that you're very well aware of in the press. Well, 10 to 12% of those vaccinated exposed patients also have a long COVID phenotype. So, while we try our best, often there are statistics that show us when we look back, and we're learning from a lot of mistakes that we did make. And I think medicine and science need to be honest about that, instead of just mollycoddling it and making it very sugar-coated. We did make many mistakes. When we look at child and adolescent prevalence, this is based on very poor figures. We all were rushing to publish and put numbers out there. So there were a lot of studies that did not have good data. They weren't good controls. And a lot of children were acutely suffering, but mostly mild. So we mostly see that most children with long COVID are teenagers. And of that, we think the prevalence today is about 25%. And that's based on a study done last year, but it's ongoing and it's likely underestimated. Research is based on the questions we ask. And sometimes as doctors, we have to ask, am I asking the correct question today? Because if I ask the wrong question and I get an answer that's incorrect, I give that to you for another year or two. And this is why it's important for me to engage with you as the public, to meet you halfway. Because if I don't listen, I can't ask the right questions. And this is what I hope my colleagues over the next few months to years will take heed of even more. So when we look at the last, the NICD stopped showing daily cases and numbers. It was creating a lot of fear. My sister and mother were just looking at these numbers, so many cases today, and this next wave is coming, and all these words we used. We've had about 21 million positive COVID tests done, of which, 21 million tests, of which 4 million were positive. So that equates to what, maybe about 400,000 long COVID patients if we look at things. I'm just going to move to the next slide. So just with COVID, I tell every patient I see, I'm going to give you 3 theories of why we think long COVID exists. just like you may have herpes infections or another infection called glandular fever with a virus named Epstein-Barr you may be aware of. We seem to have one theory is that we have reservoirs of disease. So basically viruses hide in your immune system, in your body, and your immune system can't catch them. The immune system doesn't know where it is. So it keeps activating the immune system and creating more inflammation. So we think that COVID likely is having reservoirs of disease. And the reason being is that when we take biopsies of the gut or of the brain or various lung tissues, there are remnants of COVID proteins, and these are in long COVID patients. So the inference is that there may be some viral proteins or existing COVID in subclinical infection that's just causing this long COVID syndrome. So from those of you that may Google, and most patients are more well educated than doctors give them credit for. They're very desperate, they're very frustrated, they're very isolated. So they're well aware of their symptoms. A lot of them have fatigue, shortness of breath, stomach issues, irritability, anxiety, depression. Some of them say they can't remember things. Noises and sounds affect them. They can't keep relationships for long. They can't keep work for long. And I think that's what the ME/CFS community has also been screaming about for years. And perhaps long COVID was a blessing to these patients because it brought things to the fore. And ME/CFS, I'll go through it in a second in the fourth point. But that is not just related to COVID and COVID exposure. There's multiple post-viral and post-bacterial infections that could also cause this syndrome. And so when we look at the immunology, and this is for the doctors, because I'm hoping that we're not just going to be looking at the community and telling you what you want to hear. I'm hoping that clinicians also realize that I am a scientist and I am a doctor, and I just need engagement, and we need to start cross-collaborating. I find that in South Africa, I decided to open my practice in a prestigious area called Camps Bay in the hope that I would get buy-in from more wealthy families and also offer the poor an opportunity for first-class health. I thought since 2020, I would be able to engage commercial lab structures, community members within the area I was in, as well as private clinicians. But sadly, I noticed that we have an extremely siloed, fragmented, and exhausted system. Doctors, often in private, are busy making independent practice money, and the ability to connect with another doctor to service the needs of working together for a patient often goes astray. So when we look at the immunology, each organ system should be a specialist doctor that should be looking at it. If we look at the team approach, when I look at the immunology and virology, we're showing more or less, and it's a very basic talk, but there's T-cell exhaustion. So basically your immune cells really get tired. We can see certain levels of those immune cells. Some of them, we call them T effector memory cells and T central memory cells. There's certain cytokines that we can pick up in the blood, and those are messenger cells in the immune system that are either elevated or lower in long COVID patients. And if we assess them in different parts of the body, it can infer what's going on, and we might be able to develop better tools to better manage and prognosticate these patients in the future. When we look at the vasculopathy of these patients, so it's basically, you may have seen it in the press that some patients suffer with microclots. And we were very fortunate, Stellenbosch University did some really lovely work on looking at clotting in patients with long COVID. This has also been known in the ME/CFS community, so we knew where to ask questions. What it basically means is that there's microscopic clots that basically cause a lot of inflammation in multiple organs. So the mistakes we made with COVID is that we told people in the beginning it was a respiratory disease. You need to look at your SATs, you need to look at your breathing, and you need to do certain blood types, and that's how we knew we needed to put you in ICU or not. And clearly, we're looking backwards now and realizing it was a multiple organ disease from the start. So we basically lost a lot of time based on our hypothesis of what we thought was going on. A lot of patients with mind fog, and we look at their brain scans, we can look at this spinal fluid, we can see how difficult it is to diagnose these patients. Most doctors do standard tests, and the reality is that there's a lot of data from the ME/CFS community, and very seldom doctors consult that data, body of evidence. And that is why the patients are often told that have long COVID today, all the tests are normal, I don't know what's going on, and the patient gets frustrated, leaves the doctor and shops to another doctor. And that's the current state of my practice, where a lot of patients have spent up to 100,000 Rand already doing tests at maybe 5 or 6 doctors before they walk through my door. And there's no bank accounts, there's no job, and I have to learn to do my best for them. When we look at ME/CFS, the basic definition is, just for people in the audience, is that you had an insult. It's either a virus or bacteria. In this case, we'll say it's COVID. And depending on which wave you were lying in and which vaccine you got exposed to, that's an important thing. But when you've got an impairment or reduction of your social, work, play, and exercise functioning for a period of greater than 6 weeks, you have post-exertional fatigue. You could have, in relation to your posture, you could have tachycardia syndrome. So your heart rate is extremely high. Some patients are also responding to, there's a syndrome called mast cell activation syndrome that is exposed to other diseases and syndromes as well, not just COVID, but it's just basically your body produces too much of histamine, and we can try to dampen these symptoms. So when you look at lungs, a lot of patients complain that I'm really short of breath, doctor. The doctor did the X-ray and it said it's normal. Reproductive system. It's very often as South Africans in clinical healthcare, in private medicine, we never ask patients about their gynae history enough, their sexual history. Often women, before they get their periods, long COVID symptoms get much worse. With males, the inability to tell the doctor about erectile dysfunction or embarrassment with their partners with neurocognitive symptoms. There's just so much of discord, and I think COVID separated us. We didn't have good support systems, and with these symptoms, we get more stretched away from health systems and help. When we look at the gastrointestinal, most of us, if our gut is not right, our mood is not right, and a lot of them are having diarrhea, bloatedness, stomach cramps, particularly in teenagers. It's a big symptom I see in South Africa. And I'll come to kids in a second. It's just a little diagram. For those of you who need any data or any journals, please reach out to me. I'll give my details, and I'm happy to furnish them with these journals. I'm hoping any colleague would reach out to me too. And I really hope I can spread words where I'm speaking a bit for the public, but as well as for doctors and nurses, so that we could spread the correct message, stop allowing patients to be opportunistically poached by business people trying to cure them of their long COVID, and start learning more about our South African community of long COVID virus. This is the theories that I explained. So viral reservoirs of disease, COVID can cause severe inflammation, and COVID also activates autoimmune diseases. And I can come through that if you guys ask any questions later. I can go through it in depth if there's any audience members. When we look at children, children have multiple symptoms. Unfortunately, majority of the studies that were done had only asked for very few symptoms. So most studies actually ask for 10 symptoms, and there's likely over 200 symptoms of people suffering after a COVID infection or mild COVID disease. Children are likely protected in the younger ages, as we all knew, and it's when they become teenagers, that's when we start seeing a bit more of long COVID symptoms. And the theory behind this is that smaller children have what we call a thymus, so they have a protective immune response to COVID and chronic complications of COVID. When we look at the complications of COVID in children, it's usually two of them. The first one is a severe immune, it's like a storm that happens, and we call that MIS-C, M-I-S-C. And that's something that close to 70% of these children end up in an ICU setting, and we really have to life and death give them treatment to cure them or to dampen what's going on. The second thing is long COVID. Now, there's not South African data at all. I am seeing teenagers running from doctor to doctor, and the majority of times it happens in the adults, but they're often called depressed, anxious, socially isolated because of lockdowns. And it's really shocking for me that I'm sometimes seeing 8-year-olds and 9-year-olds with 3 antidepressant drugs already prescribed by a doctor. And We are not working together as a team to optimize these patients. We are billing, we trying, we are telling them there's no answers, but you just have to figure it out on your own. And these patients are ending up on YouTube, getting lots of misinformation, or coming to their own conclusions and treating themselves. And I ask myself, is this the South Africa we all dreamt of? Or is this the world we all dreamt of? And I'm coming back to the word community, and these are the things we could actually fix by doing very simple measures of just listening to people, hearing them out, and seeing where we can go. So there's been some South African studies, and a lot of patients tell me they've gone to this long COVID clinic, they're super desperate, but a lot of our long COVID clinics, our colleagues are doing their best, but they are likely just gathering data, and they're using it to inform future studies. And we have a wing called evidence-based medicine. So we will only advise the public after we've got evidence. But that leaves so many patients in the lurch right now. And so my practice's aim, along with various colleagues I'm trying to build a team and network of, is to dampen symptoms in these patients. And we've got quite a scientific strategy behind it. And my aim is to improve patients' symptoms by 60% within 60 months, because quality of life counts better than cure. So when we look at the diagnostics, I've reached out to private laboratories in South Africa. The problem is these are commercial labs. I worked in academic labs in universities, and in South Africa, if labs don't make money or they don't have infrastructure, they will not invest in certain tests if there is not a demand for it. There is a test that I would like to get into our country. It's by in-cell diagnostics, and that actually proves that you have long COVID. There are a lot of adult patients who can't get policy payouts because the insurance companies just say there's no proof, and very few doctors are invest in a diagnosis of long COVID or CFS. It's also the problem. There are existing tests and there are existing workups that we can do, but we need buy-in from communities. We need buy-in from doctors. We need a lot of campaigning like these events to get the word across what evidence is available. And I actually think if doctors and nurses actually reached out to data that's existing within the ME/CFS community, a lot more questions and good answers could be found. Currently, as with all patients, there is no cure. We don't have a good body of evidence that this is a one-size-fits-all cure, and this is the treatment Dr. Naidoo or so-and-so gives you. There is no cure. The aim is we dampen symptoms, and there's good strategies involved in this. And as with every time you see a patient honestly just needs support these days. And 90% of my consults is emotional reassurance and support. If you need to reach out to me, when we look at each symptom, there's lots of pharmacological as well as breathing exercise related things that we could do to dampen symptoms in patients, particularly with teenagers. This is my interest is mostly lying with teenagers at the moment. So I'll give you an example of just a quick rundown, just so people could hear it as I verbalize it, but the slide is up. We can decrease the heart rate. With immune dysfunction, we can find out the gaps in your immune system and try to plug them in. We practice pacing at every opportunity, small activity, big rest with patients. Those are patients with neurocognitive symptoms, headaches, mind fog, loss of memory. There are available drugs that I'm actively using right now. Autoimmune disease that COVID could trigger in a predisposed patient. There are some things to arrest it, and one of them are called G-coupled protein antagonists, and PC07 is one of the drugs that are there. There's a lot of expensive treatments that are available. It's still experimental, but you know, we need to try it on various patients. And my practice in Camps Bay, I've got a vast array of different demographic groups and socioeconomic brackets. So I'm actually able to curb these symptoms on patients quite easily. Vitamin C, I've learned this from the Europeans, as well as my time doing tuberculosis research. This really dampens viral reservoirs, but also calms down any inflammation that's in the body. So we can vaccines, those that are should be better during Delta waves, but those that are triple vaccinated, I think the jury is out at the moment. We're not too sure whether you need to be just boosted to prevent long COVID. And the second variant, B.2, seems to be giving more long COVID in the Omicron variant than with the previous variant. Just quickly, we've made a lot of mistakes. We've got lack of knowledge amongst doctors at the moment. And at the moment, I just recommend with what's going on in their lives. And each community, each race group, each culture has a context of suffering. And we have to support this based on the division in this country and trying to protect these type of vulnerable long COVID. These health institutes, as well as researchers and policy funders. This is a quote by me, and I just genuinely continue to be humbled by this process of long COVID I'm experiencing, as well as hearing of the experience of my patients. I will always continue to be guided by hope, and that's something that I hope in my last always walk ever so light. This is my practice details, and it'll be online. So it's a QR code you can scan if I can't help you, or if you are not the right patient for us, I will promise you I'll try to get the right person. So please feel free to reach out to me anytime you may need something. And I really thank you, and I'm sorry I went over time.